care for cardiogenic shock. So, here are my conflicts of interest, nothing particular. With cardiogenic shock, you are well aware of this, but cardiac insufficiency is cardiogenic shock represents the most serious form of cardiac failure. The area has varied greatly in recent years. What we can say in summary is that we should take the most simple definition, which represents a clinical reality, and basically it's hypertension which is less than 90 grams of mercury with variations of 95 in some studies for over 30 minutes. They do not respond to the pre-charge with signs of hyperperfusion, peripheral hyperperfusion. Were there any evolutions in the diagnosis of cardiogenic shock? There was one definition, but different profiles of the seriousness of the cardiogenic shock. I think cardiogenic shocks, you're familiar with the definitions that were published in 2012. Cardiologists are perhaps not so aware of them. This definition, this clinical definition, is associated with an evolutionary definition. In other words, a crash and burn patient, a patient who requires immediate support, as opposed to the patients where we can provide inotrope support, where we have a little more time to consider the strategy. Now, there's some lacking features in this definition. Looking at the clinical situation, the first lack is the definition of pre-shock. What we need is a definition or a sign, a patient who has been admitted for myocardial infarction, and others. What we're also missing is a consensus on what we call refractory shock. In other words, where you have to consider support assistance, and where one is looking at the timeline for setting up the assistance. We can talk about this during the discussion phase. Has the epidemiology changed? The answer is yes, and you can see that this is a problem. This is a study that was published by Nadia Aissaoui, who works at the Georges Pompidou Hospital, who took the FAST MI database and worked with Catherine Inflammatory to establish the frequency of cardiologic shock. And what she showed between 95 and 2005 is that the frequency of cardiogenic shock is declining. In myocardial infarction, we're going from down to 3.6%, from 8.7%, and mortality has also slightly declined. It's around 50%, and therefore the mortality, of course, is still much too high. So the implication, and in particular for cardiologists, is that it is a rare pathology that we don't often encounter. It's looked after most often through interventional cardiology and then in USIC, and 2/3 of cardiogenic shocks occur after admission. Now, why is this a problem? Because most of the time the patient is transferred to the ambulance. We have an ECG qualifying for reopening the thorax with an angioplasty, and the client will be in a catheter room, which is a hostile environment, a dangerous environment. Why? Well, because the angioplastician tends to leap onto the patient to open the artery as quickly as possible, showing that he's the fastest of all. But no, what you need is to consider things, to think for 4 or 5 minutes. And in all infarctions, you have to have all the predictive aspects suggesting a cardiogenic shock. So you have to be like the Buddha before you become a cowboy. In other words, you have to talk to the patient, to refer to any case history of diabetes or previous angioplasties. You have to quickly diagnose him, talk to the ambulance team, you have to ausculte him, And you have to do an ECG to see how much of a necrosis there is, to see whether type of infarction it is. And what is most important, you have to do an ECG as quickly as possible before the angioplasty. This may surprise you, but this is what we do as a matter of course. So echocardiography to establish how the left ventricle is working and to establish whether there are any mechanical complications which lead to, in fact, cardiogenic shocks in 10 to 15% of cases before you actually put in the stems. Looking at the angiogram is important. It's not simply deblocking, it's assessing the extent of the lesions, but if there are other stylosis, this is going to help with the diagnosis, and you may well have to do a ventriculography if you've not done it previously. Looking at the presentation number 3, there's only one type of treatment that works in cardiogenic shock. It's revascularization, which has proved how effective it is and which reduces mortality. But there are different forms of angioplasty. You have to be able to analyze the result. Here is the example of a patient who was suffering from occlusion, and you see that the result is good. The coronary flow is disastrous. You see that he has perfectly done his job, but in functional terms, in fact, we were not able to help the patient. And you have to ask whether it's full vascularization or not. Do we have to complete what we're doing? We have to remain modest and consider that perhaps my angioplasty was not fully successful. And this may make the prognosis rather worse. Some patients may have, after the angioplasty, you have to ask questions. Some patients may need cardiac support, and in some cases before the angioplasty, because we're not able to stabilize them. And other patients do not suffer from cardiogenic shock, but you have to watch them very closely on clinical aspects or biological or ecographic aspects, and on the renal functioning, on diuresis, which have proved that there was a link with cardiogenic shock, and on lactates, which are an important predictive factor for the development of a shock. And this is probably not widespread in IC units. Now, just a few words on the inflammatory syndrome, which you know better than I do. It is also correlated. It has been covered by medical research regarding cardiogenic shock. And then there's echography, and you're moving on to the second phase. In other words, it's no longer the quick echography to see the functioning of the left ventricle, to see if there are any mechanical complications, but it's an ecography that has to be done by somebody highly experienced to answer the question of establishing what is the cardiac output, what are the filling pressures, the preload pressures, how is the right ventricle faring if we're wondering whether to provide cardiac support. Can we do this only on the left ventricle, or are we going to have to provide biventricular support? Here are a few examples of ventriculography, looking at the aspect of thrombosis, which is more visible on the apex of the left ventricle, and also the right ventricle is on the right side video, which is very dilated, which suggests the need for biventricular assistance. What can we say about catheterization? Well, it's not recommended as a matter of course, but in my modest opinion, to summarize the guidelines, these tables where one cannot understand why the patient is suffering from cardiogenic shock or why there are difficulties in assessing the cardiac output, looking at the preload pressures. But If you are in the situation of a patient who is gradually moving towards cardiac assistance, a catheterization of the right ventricle is necessary to assess the pulmonary resistance before looking at a transplant. It has to be, you have to have a multidisciplinary approach. There have been several articles, I believe, on this particular theme. In other words, the patient who is under cardiogenic shock, well, you have to be able to hand over in some centres, in particular for cardiologists. In other words, transfer your patient to multidisciplinary centres with experts who will be in the same place with cardiologists, vascular surgeons, assisted life support systems, transplant systems, in order to be able to provide the full range of care for cardiogenic shock patients, and to be able to establish whether the patient requires support or not. To conclude, and to keep it simple, you have to remain vigilant. You have to keep things simple. You need to have, first of all, a clinical diagnosis of the cardiogenic shock, and you have to examine the shock before it happens. In other words, gather all the information that will enable you to predict the evolution towards a cardiogenic shock, to gather the cardiological aspects, the hepatic, renal aspects, to have the echography, the electrocardiogram, to remain vigilant, in other words, to detect the predictive factors for a shift towards the shock, and for the cardiologist, you have to analyze the results objectively when you do an angioplasty, and transfer the patient early on into a specialized center. And to conclude, like many things in medicine, it's teamwork. Thank you. Care for cardiogenic shock. So, here are my